Okay, well, it's time to bring together everything we've covered so far and consider how we're going to use information to improve our practice around extrication. So we started out by hearing from Simon about the significant mortality burden associated with road traffic collisions, and that's despite all of the increases we've seen in road safety. Importantly, though, we also heard about the even higher rates of injury and the often forgotten about psychological impact of being involved in road traffic collisions. And I guess all of that set the scene really nicely to help us consider how we can make a difference to these patients. We also heard that 50% of road traffic collision deaths occur before arrival at hospital. And even for patients that do get to hospital, a significant percentage of those die within 4 hours after the crash. And all of that pointed to the fact that patients involved in road traffic collisions often have time-critical injuries. And the way we're going to improve outcomes for those patients is to ensure every link in the chain of survival is strengthened. And within this course, we're really focusing in on element 2 of that chain of survival, the early rescue to reduce time to treatment. And we now know, don't we, that previously our belief that extrication should be modelled around the potential for spinal injury is probably wrong, and the techniques we were employing weren't performing as well as we expected. And in addition to that, the Exit project has provided us with incredibly rich data around injury outcomes, biomechanics, and the psychology after road traffic collisions. And with all of this new evidence-based knowledge, I think it's become really clear that the current guidance and the way we approach extrication needs a serious rethink. So, acknowledging the need for change, a group of experts was brought together for a consensus meeting. They sat down, they looked in detail at all of the evidence available to them, with the aim of agreeing by consensus on a new approach to extrication and to create a new set of evidence-based guidelines to direct our practice moving forwards. And that is what this final presentation is looking at, the outcome of those discussions and the recommendations that were developed from it. And these new guidelines really do represent a significant change in the way we think about extrication. We've moved away from movement minimization for all towards a patient-focused approach to extrication. There's also a real drive towards a shared approach and understanding of extrication practice to improve our interoperability on scene and create conditions for seamless working between all agencies at the roadside. And I think really importantly, every responder is empowered by these guidelines to implement positive changes on scene to ensure optimal and timely extrication, care and transport for patients involved in collisions. So, look, without further ado, let's get into this guidance and the 14 consensus statements which make up the document. I'm going to try and talk through them in a roughly sequential manner, so if you're referring to the document at the same time, don't be surprised if I'm dotting about a little bit. So, historically, and I think still in many current practices, fire and rescue service personnel often arrive at the scene of a collision and one person is deployed to provide manual inline stabilisation, or MILS, for patients who are still in the car. Now, the idea behind this has always been about achieving absolute movement minimization of the neck. But the evidence now says that if a patient's fully conscious, they're already able to keep their neck in a position that's comfortable and safe. And so in those cases when the patient's conscious, MILS doesn't actually add any value, and in fact it can have some unintended downsides. It ties up personnel that could be better deployed to a different task. It prevents the option of self-extrication because you're literally holding them in the car, and ultimately it prolongs the entrapment time, which we know can negatively affect outcomes. So what do we need to do? We need to stop the automatic use of MILS and focus instead on approaches that are actually helping, not hindering, the patient. Now, talking about approaches that help the patient, this is potentially one of the biggest changes of mindset that we're going to find in these guidelines. Because one of the most interesting findings from recent evidence is that self-extrication, when the patient gets themselves out of the vehicle, is actually associated with the least spinal movement and the fastest extrication times. And so self-extrication, or minimally assisted extrication, which I'll talk about in a second, should be the standard first line extrication for all patients who don't have contraindications. Now, of course, self-extrication isn't going to be suitable for everyone, and there's probably two key reasons why someone shouldn't self-extricate. And that's really if they can't understand or follow instructions, and or if they can't stand on at least one leg, and whether that's due to their injuries or their usual baseline mobility. But here's what's really important though. Self-extrication is appropriate in more situations than we might assume. It's suitable for children who can follow instructions. Patients with neck or back pain can be invited to self-extricate because remember, this technique results in the least movement of the spine. Even those patients with non-specific neurological symptoms like tingling, for example, and even those showing signs of central cord syndrome. I think it's really important to remember we're not saying this patient isn't injured or even that they haven't potentially damaged their neck. All we're saying is that they are able to get themselves out of the car, and we know from the evidence that this is the fastest and the safest option for them. So I said I'd mention minimally assisted extrication. So we know from the previous slide that every patient should be considered for self-extrication. And when we look at the data, something quite surprising comes up. And that's that the ability to self-extricate is pretty consistent across all age groups when we factor in things like injuries and overall physiology. And that means that, as an example, older adults might be just as capable as younger people, depending on the situation. But some patients, either because of the nature of their injuries or their pre-existing physical conditions, might not be able to get out of the car completely independently. But that doesn't mean we should discount self-extrication, because with a small amount of assistance, those patients might be able to get out of the car. And this minimally assisted self-extrication can open the door, excuse the pun, for even more people to benefit from this approach. And just to be clear, assisted self-extrication doesn't mean dragging the patient out of the car or lifting the patient out of the car. It's about gentle support, maybe offering an arm to help someone to their feet, helping them to stay balanced, or providing a little bit of traction using a belt. I think it's subtle, it's controlled, and it's respectful of the patient's own inherent ability. It's helping where needed, but not taking over. Now, if you're attending this course as a non-clinician, then it's understandable that you might be wondering where you come into this and what you're able to do. Well, a really important aspect of these guidelines is that they empower non-clinical responders to take action, including getting patients out of their vehicles. And that's really valuable because often non-clinical responders like the police, fire, highways, they're arriving on scene first before the ambulance service. And so by initiating the extrication process, you are going to reduce on-scene times and to allow the patient to get to definitive care more rapidly. So the big take-home point here is that extrication should not be delayed just to wait for a clinician to get there. And then look, there's a great tool embedded into the guidelines to help non-clinicians determine the most appropriate means for extrication. This extrication decision tool asks 3 questions which we need to address in order. Firstly, remember, self-extrication is our standard first-line approach, so we have to ask, can the casualty self-extricate? If they can, great. But if they're unable to, then the next question is whether a snatch rescue is indicated. Now, you're going to take this option if there is an immediate threat to life. What does that mean? Well, if the environment is life-threatening, for example, the vehicle's on fire, or the patient is in a life-threatening condition, which means they're unconscious and you think there is absent or ineffective breathing. Those are the patients that need to be brought out of the car as rapidly as possible. And I guess finally, if neither self-extrication or a snatch rescue is indicated, then we need to consider how to extricate the patient in the quickest and most appropriate fashion. And we're going to come back to that group later on. Now, just focusing a little bit more on the decision as to whether the patient can self-extricate, there's a really useful mnemonic to help with this called "You Step Out." Now, it's specifically designed to help non-clinical and clinical responders make safe and informed decisions about whether self-extrication is appropriate and how to facilitate it so it's maximally effective. So let's just run through it. Firstly, we've got to be satisfied that the patient can understand what we're telling them and what we're asking them to do. And when we're communicating with them, we need to remember that throughout our conversations, we should be calm and reassuring. We're then going to ask them to try and move both their arms and both their legs. And if they're able to, even if it's a bit uncomfortable, then they are a candidate for self-extrication. Obviously, if it's too painful or they're unable to move, then we need to consider an alternative approach. And then we need to ensure the door is wide open. We've got a clear path to a safe place for the patient to get to. Now, that might be a chair to sit in, it might be an ambulance stretcher to lie on, or if the clinical responders haven't arrived, it might be a safe place away from the road and ideally protected from inclement weather. And then finally, when all of that is in place, we can invite the patient to step out of the vehicle, remembering that we can offer a small amount of support if necessary. Now, before we move on from self-extrication, there is one final item to discuss, and that's collars. Now, when it comes to cervical collars, recent systematic reviews haven't shown any clear clinical benefits. The biomechanical studies do suggest that collars can reduce maximum neck movement, but interestingly, when someone applies a collar in the vehicle and then the patient self-extricates, the total neck movement is about the same compared with if they extricated without a collar. So the benefit or otherwise of collars is still a bit grey. But while we're waiting for more definitive evidence on the benefits versus the potential harms of collars, this is the current guidance to keep in mind. If you have got a patient with a suspected serious neck injury, like neurological signs or a lowered level of consciousness as demonstrated by a Glasgow Coma Scale under 15, along with significant injuries elsewhere, then a collar should be applied during entrapment and extrication. And in that setting, I think we need to remember the collar is an extrication device. If there's no neurological injury, then the collar should be removed after extrication. And beyond that situation, local clinical protocols will really guide you as to whether a collar is needed during ongoing assessment and transport. So collars aren't a one-size-fits-all solution, and I think it's important to balance safety with evidence as we continue to move forwards. Okay, so look, we've talked a lot there about non-clinical staff being empowered to make decisions about extrication methods. But what if the patient's trapped in their vehicle? Well, remember, everything we do on scene needs to benefit the patient and reduce their time on scene. So if the patient is trapped, one option that should definitely be considered is vehicle relocation. This, again, is something that can be started prior to the arrival of any clinical staff. And the technique, importantly, is supported by the National Fire Chiefs Council's National Operational Guidelines. So keep in mind, moving the vehicle itself can sometimes be the quickest way to get someone out of the car and on their way to definitive care. And that can make all the difference. So let's move on now to consider what happens as the scene evolves and more responders, including clinical staff, start to arrive. At this point, hopefully, the non-clinical responders have used the extrication decision tool and removed any patients from the vehicles who could either self-extricate or required a snatch rescue. Therefore, any patients left in the car are likely to be trapped either because of their injuries or because of mechanical entrapment. And inherently, these patients land onto section 3 of that decision tool we talked about previously. And that means we need to deliver the quickest appropriate extrication. And I promised we'd come back to that group. So these patients will require a patient-centered plan of which the primary focus is on minimization of entrapment time. And to minimize that entrapment time, we're all going to be needing to work together on scene to develop and execute this plan. Now look, I know I keep on banging on about this time factor, but for this group of patients, the ones who are trapped, it's really important because the evidence tells us that when someone's trapped in a vehicle after a collision, they are more likely to have serious injuries. That means higher rates of interventions, complications, and potentially death. But here's the challenge. It's actually really difficult to identify which patients have got time-critical injuries just by looking at them, or even after a clinical assessment within the vehicle. And that's why the primary focus is on minimizing entrapment time. We simply can't tell who is the most injured in a lot of cases. And we've talked about the fact that traditionally our extrication methods focused on minimizing movement as much as possible with the idea of protecting the spine. But the new biomechanical research has shown that those movement minimizing techniques aren't actually doing what we thought. In fact, they don't significantly reduce spinal movement. And interestingly, rapid techniques like a B-post rip result in similar levels of spinal movement as the slower, more cautious approaches do, like taking the whole roof off. So that is something we really need to reflect on as we look to update our operational guidance. So I said on the last slide that assessing patients' injuries accurately in a vehicle is extremely difficult. But what if they present with paralysis or other really clear neurological signs which indicate a potential spinal injury? Well, Rob talked about this already, but let's go back over the key points just to be clear about how we're going to act in this potential situation. So let's start by looking at the numbers. Remember, only about 0.7% of patients who are trapped after a motor vehicle collision will actually have a spinal cord injury. And interestingly, about half of those are also going to have another serious injury elsewhere in the body. Now, why does that matter? Well, because those other injuries can affect things like blood pressure, breathing, and overall physiological stability, all of which can worsen spinal cord damage. It's not movement that is our enemy here. We often hear about minimizing spinal movement to protect the cord, but the real issue is that we can't meaningfully optimize spinal cord protection with things like oxygenation and good blood supply while someone is trapped, especially if they're unstable from other injuries. And here's the kicker. Extrications focused on absolute movement minimization not only take longer, but they don't actually achieve less movement compared to the other methods. So, when tool-based techniques all produce similar spinal movement, the evidence supports us with a simple principle. Go with the fastest, safest option. Time matters for these patients, and getting them out quickly makes a real difference, particularly if you've got a genuine concern about their spinal cord. Okay, here's an interesting one. How many road traffic collisions have you been to where the patient is sat in the car, the patient monitor is on the roof, and the ECG leads, the blood pressure tubing, the saturation monitoring wires, and so on are snaking their way into the vehicle? Quite a few, I dare say. Well, it's time to take stock and consider what we're doing there, because if we accept that it's very difficult to accurately assess the condition of trapped patients in the car, and we're always aiming to achieve the fastest, safest extrication, why do we need all that monitoring? I think the monitoring should only be used if they are truly going to benefit the patient overall. The same goes for a detailed clinical examination. Pausing extrication for clinical and physiological assessments can lengthen the time someone is trapped. So we've just got to keep it in the back of our minds. It's important to weigh up the harm versus the benefit of routine, regular, repeated observations during extrication. And we should only carry out these checks if they're really likely to lead to a meaningful intervention or a change in care. I think the goal here should be to keep things moving efficiently without compromising patient safety. And really, following on from that previous slide, it's not a particularly large leap to realise that providing clinical care while a patient is still trapped will also potentially prolong extrication time. So it's important to focus only on time-critical interventions, or those that can help speed up extrication. So stopping major hemorrhage, early administration of TXA, or giving pain relief to help somebody self-extricate are examples of interventions that might be appropriate to deliver within the vehicle. But more complex procedures, things like advanced airway management, should really wait until after the patient is fully extricated. The goal again is to balance urgent care with getting the patient out as quickly and safely as possible. And one last slide on the clinical interventions that we might be providing. Pelvic binders. These are often utilised in this group of patients, but if we're going to apply one, then we need to be doing that once the patient has been extracted from the vehicle. I don't know if you've ever tried to apply one in a vehicle, but it's very tricky and almost impossible to do effectively. Because of that limited space, because of the patient positioning, putting the binder on in an optimal position is extremely challenging, which therefore reduces its effectiveness and so totally negates the potential benefit of putting it on earlier. And once again, attempting to apply the binder in the vehicle is clearly going to have the potential to extend the entrapment time and delay definitive care. So for patients who've got a suspected major pelvic injury, the priority once again should be to undertake the quickest suitable extrication, and once they're safely out of the vehicle, they should be reassessed, and if a pelvic bind is indicated, then it can be applied correctly and effectively. And that approach balances the need for timely extrication with the provision of essential care. Right, changing tack slightly now and onto something that I think we need to consider and really embed into our practice throughout our time on scene with patients involved in collisions is the psychological aspect of these incidents and how we can best support patients through this extremely stressful experience. Because one thing that patients who've been extricated consistently report is how important communication, explanation, and companionship are during the whole process. Having someone, let's call them an extrication buddy, with appropriate PPE on inside the vehicle, explaining what's happening and offering reassurance can really help reduce their distress. And it helps even more when the rescuer connects with the patient personally, using their name, for example, and talking them through each step of the process. We said earlier on that we're moving away from placing mills onto all of our conscious patients. So instead of that, think about deploying someone to be in the car as an extrication buddy, because that is going to have a far more positive impact. Some other stuff to think about nowadays, with mobile phones, patients expect to stay in touch with family and friends during their rescue. And if it's safe and appropriate, they should be allowed to do that. But there is a darker side to this technology. Patients have often expressed how upsetting it is when bystanders take photos or videos at the scene and then share them on social media. That can cause serious psychological harm. Some countries have actually introduced laws to prevent that kind of recording, and I think we should try to take steps to limit onlookers' abilities to capture content at the incident scenes if possible. And I think it's also important for responders to be mindful, because organisations often share photos from incidents publicly, but patients find that intrusive and distressing. I think patients are generally okay with photos being taken for internal training, but not necessarily for public sharing. And finally, I hope it's been clear that these guidelines embrace the ethos of an integrated, coordinated, team-based approach to extrication. Everyone and every response agency has a role to play in ensuring that patients involved in road traffic collisions get the best possible care, and that starts with evidence-based extrication. But to ensure that our multidisciplinary approach is effective, to understand this new approach, to talk the same language, to have the shared understanding of what needs to be achieved, we need to develop targeted training across all involved groups. And the curriculum underpinning paramedic training should be standardised with clear evidence-based focus on managing entrapment in motor vehicle collisions. And we need to work on practical tools that help improve communication on scene, making sure everyone knows what's happening and what's needed. And finally, another aspiration is to have a single point of contact in each ambulance trust, air ambulance service and fire and rescue service. That'd be really valuable. That role could coordinate training, review cases and help ensure that protocols and procedures work in the real world. So, in summary, this consensus statement is all about how we implement an evidence-based, patient-centered approach to extrication, which acknowledges the value of every responder that arrives at the scene of a road traffic collision. These 14 points are the culmination of years of research, and it represents the current best practice around extrication, moving us forwards from our historical practices and debunking some of the myths that have previously surrounded extrication practice.
Well, that is a really interesting talk and a really useful document, actually. And it's great that we've now got, a common goal and common idea of what we're going to be doing, irrespective of sort of what stream of responders we are. We can all really sort of tailor the best care and being time efficient and sort of delivering the best care in a timely approach. And also really interesting to see that we can provide a bespoke package of care depending on what the patient is in front of us. So we were talking about being tied up before, weren't we? Of, having to keep the patient absolutely still, but we can sort of weigh up the risks and the benefits. We can see what the patient can do in front of us. And then we can then deliver the right extrication package as quickly as possible and as safely as possible to get that patient to onwards care.
Yeah, I mean, I think, as James touched on, I think what this does is it gives us all a common approach to an incident that we might go to, and that addresses like the most common things that will come across first. So that question 1, can the patient self-extricate? Well, there you go, that's half your workload done. If they can do you step out, and you can do that really quickly, delivered within 30 seconds, perfect. And that can be done by anyone. It doesn't need to be necessarily a clinician who does that. Do you know what I mean? I think they should have some training. This is the training. It's about how you do it and how you structure it. But yeah, essentially, once you understand the principles of why we get them to move their legs, why they have to understand what's going on to make sure they're fully alert, then great, you can self-extricate them. But then understanding that's next question is is there a snatch rescue indicated, and therefore you get them out straight away. But after that, it's this common goal of delivering the quickest deliverable extrication method, whatever that might be. And that will change. And this is the important thing to say, is that fire and rescue services, you can't go getting rid of all your cutting tools, because there will be times when you'll need to cut cars. It's just that you don't need to cut every car anymore. And likewise, highways agency, police, absolutely you can use you step out. Imagine the safety implications of a live carriageway, getting that patient to a point of safety rather than having to leave them in a vehicle. It allows for like earlier opening of highways. There's lots of soft benefits around the sides that come alongside these patient-centered ones. But let's be honest, what we're focused on here is the patient benefits, isn't it?
So one of the powers of all of this new work is that empowerment of the non-clinical responders, who are quite often on scene first, not through any fault of the ambulance service, but just through response times and through proximity to incidents. They're the ones who are on scene first. And so it's absolutely right that we give them the knowledge and the power to extricate these patients, either with the you step out when they can get themselves out themselves, or the snatch rescues when there is this immediate kind of threat to the patient's lives. And really, it's only those patients that we've already talked about in that kind of slightly grey zone in the middle is where clinicians should get involved to design that slightly more bespoke patient extrication pathway. But I totally agree. I think this non-clinical responder empowerment is really, really important.
I think one of the fears that always comes along with it is, you're asking a non-clinician to clear a spine. Well, no, that's not what anyone's asking you to do at all. There's no talking about clearing of spines. What we're talking about is, we know the best thing for that person to do is step themselves out of their vehicle, because if they're injured, they need to be out. And if they have a spinal cord injury, that's the least movement anyway. Okay, yeah. We're not asking anyone that isn't clinically trained to clear spines. That's a misnomer. What we're after is just the right thing for that extrication phase. When the clinical teams arrive, that's their job. They're the experts at that.
Yeah, it's about applying pragmatism, isn't it? With a really nice framework now to hang your hat on, but also knowing that then you've got the clinical assessment that's going to happen either pre-hospitally or in-hospitally. And if we're all joined up in knowing how we're going to work, then we can deliver that spinal clearance or further investigations as we need to at the right time.
Awesome. Well, you've said it's a nice framework. Let's have a little look and see, I guess, whether it works or how it works in practice. Because, it's all very well talking about it on an aid memoir or talking about it in a presentation, but actually seeing how it's performed, there's a lot of little things that you'll pick up on, I think, when you see these next 3 sections that we've got taking us through, question 1, question 2, and question 3 of that extrication decision tool. So let's get to it, shall we?